don't be anxious and don't be afraid. And sometimes we react in ways where kind of not thinking about it helps us cope with it. But I think nowadays, knowing that there's a low risk of going blind with good risk assessment and intervention, it's just better to get checked. So just get checked with your local optometrist. It's as easy as going in on your Saturday after you've done your grocery shopping, and with an appointment, of course. And get your pressure checked, get your nerve looked at. If you've got a family history, please let the optometrist know. Don't leave them in the dark, because that'll trigger them to do a number of other things to look after you. And if you're really, really worried and you've got that family history, you can come straight to the ophthalmologist, and we do a risk assessment and combine that with the genetic testing to give more precise answers. But it's definitely not something to be afraid of. It's something to be proactive about. And for most people, it's like a get checked, get reassured, and revise every 1 to 2 years without any problems.
If you're living with glaucoma, or know somebody who is, or have been told you're at risk, you probably have more questions than answers. Why does it happen? Will it get worse? And how can it be treated without disrupting your life? Or perhaps you've heard the term, but don't know that glaucoma is actually one of the leading causes of irreversible blindness, often progressing silently until it's too late to reverse the damage. What if there were ways to detect it early and treat it effectively, sometimes without traditional eye surgery? That's what we're exploring today. I'm joined by Dr. Noor Ali, an ophthalmic surgeon and general ophthalmologist at Eagle Eye Surgeons in Sydney, where she helps patients protect and preserve their vision through early diagnosis and advanced glaucoma treatments, including minimally invasive glaucoma surgery. Today, we're going to break down the different types of glaucoma, risk factors that lead to the condition, and the latest treatment options for patients. But first of all, who am I? My name's Paul Salloway. I'm the owner of Optics Digital. We're an agency that helps healthcare professionals to grow their practice. So, hello, Noor. Good to catch up with you today.
Good to catch up. Thanks for asking me to come on here for the chat.
Excellent. So, would you like to give us the mandatory 30 to 60-second self-introduction of who you are and how you became associated with Eagle Eye Surgeons?
Yeah, so I'm a glaucoma surgeon. I've done fellowships in Oxford and Imperial College, and I've been a consultant for close to 4 years now. And I'm really passionate about helping patients with their glaucoma, adopting new technology very carefully, of course, with careful assessment into my practice, and helping people get diagnosed early and preventing visual disability and visual loss. I do all the procedures approved by the TGA. Every procedure is suitable for a different type of patient. There's always a two-way sort of shared decision making with the risks and benefits and how we go about things. I've actually known Mitch and Erica previously when we were all working through the eye hospital, Sydney Eye Hospital, and yeah, we're sort of just got in touch and said I'm interested, and here I am.
Excellent. All right. Well, let's jump into it then. So, for those who have heard of glaucoma but don't fully understand it, how would you explain what glaucoma is and why it's often called the silent thief of sight?
Yeah, so that's a very, very common question on people's minds, because people hear the term thrown
Mm.
around and it can cause a bit of anxiety not to know exactly what it means. So glaucoma, in the purest definition, is a typical type of damage to the optic nerve, or the cable at the back of the eye that takes the messages to the brain, where there's structural thinning, and then it results in changes in the side or peripheral vision. The patients start to get changes in the field of vision. If left unchecked, undiagnosed, untreated, it can even come and take away the central vision. People don't feel this happening. The reason, well, one of the main reasons, or one of the main modifiable factors in glaucoma, is the ocular pressure. So the eye, just use my little eye model here, has a system in it whereby fluid is produced in the middle part. It percolates through the pupil, and then it gets strained in this gutter over here that goes all the way around, and there's a little spongy organ at the base called the trabecular meshwork, which drains it. And the pressure goes up in the eye because of under drainage through the trabecular meshwork, and hence why there's a mismatch. The pressure goes up and damage starts happening. The trouble is, when the pressure goes up to abnormal levels that cause damage, it's not symptomatic. So the upper limit of normal for normal humans is 22 millimeters mercury. And humans don't usually feel unless the pressure gets up to 40, so twice as much. And even then, if it happens slowly and insidiously, people don't even feel that. So that's why it's called the silent thief of sight, because the pressure goes up without you knowing it unless you're getting checked. And then that structural disc damage happens. And if left unchecked and untreated, then it can then start to affect the sight vision.
So glaucoma, when it's quite advanced, is where you'll start to lose that peripheral vision. Is that right?
That's right. So advanced glaucoma really is when you're losing a little bit more of that peripheral vision and it's closing in. And hopefully we're over the age where people present with what we call sort of tunnel vision, with only a small amount of vision left now, because there's such good screening by the optometry community. And optometrists are so accessible, and people have good long-term relationships with them. The family has a good relationship with them. So then people are, getting to us sooner and earlier on in the piece than before.
And are there any sort of common misconceptions about glaucoma that you hear from patients?
Absolutely. Well, I wouldn't say it's a misconception. I would say it's probably a genuine concern, but the risk of it is extremely low. So when I diagnose a patient with glaucoma, it's often a little bit emotional. And the first reaction that the patient says is, am I going to go blind, doctor? And I say this because even my own uncle, I was diagnosed with glaucoma. And when I was talking to him, the first thing he said to me is, am I going to go blind? It's important to realize that while glaucoma is a serious condition and it can cause irreversible blindness, the number of people that actually go blind from it is still small with modern detection and modern treatment. So, and not only that, depending on your genetic milieu, some people have a more, I like to call it a piddly glaucoma, so not one that necessarily progresses a lot or damages the nerve. And some people have a more aggressive glaucoma, which progresses really quickly, damages the nerve quickly, takes the vision away quickly. And at present, it's difficult for us to know which one is which, and we kind of have to use time to learn about each patient's disease. So I would say that's the biggest misconception. And based on the current literature, it's sort of the worst 10% that are most likely to go blind from glaucoma. There is a group in the middle, between sort of 60 to 80% of the more severe types that are at risk of getting visual disability. So for example, having patches in their vision, not being able to read clearly, or not having a wide enough visual field with both eyes open to legally maintain a driver's license. So I always tell people that in this day and age, if you've been diagnosed early, you're very unlikely to go blind unless you disappear into the bush and don't contact anyone.
So I think like maybe a lot of people know about cataracts and that they know that there are, procedures, surgical procedures that can actually address that. Whereas glaucoma is quite different, isn't it? In the sense that once the damage is done, it's done. So it's really all about prevention, right? Yeah, yeah.
Absolutely. Yeah. So this is, a lot of what I talk to patients about the first time they come and see me, and sometimes even through their treatment, that it's better to err on the side of caution and do more screening, more prophylaxis, rather than wait for things to declare themselves. Sometimes I sort of have a gut feeling that based on the assessment and the things we've got, that we need to escalate treatment, whether it's add a new drop or go for a minimally invasive surgery or go for a laser or go to a more significant drainage surgery. Sometimes the patients hesitate, and I can understand that, because it's a little bit like diabetes in that you don't know that the blood sugars are going up, but it's still doing damage on the inside. So glaucoma is the same. The eye pressure rather, is going up and damage is happening, but the patient doesn't necessarily appreciate it until it gets very advanced. And so from that perspective, I think, people are less aware, and some people, because it's always a shared decision making, they take a bit more time than others to make that decision. But that's okay. With modern technology, genetic testing, we are able to make better decisions, more personalized decisions, more accurate decisions, to keep people from, developing that visual disability or getting into that zone.
All right. Thank you. All right. Well, there are, I believe, several forms of glaucoma. There's what they call open angle glaucoma, angle closure glaucoma, maybe others. So can you walk us through those main types and how they differ in terms of the symptoms and progression?
Absolutely. So glaucoma is sort of an umbrella term for a number of conditions. And the thing they have in common is they all cause a progressive thinning in the nerve or the cable at the back of the eye that we talked about before, which is this nerve right here, comes out back, goes to the brain. There's different subtypes. The common factor in all of them is it's pressure mediated. So if we go back to that drainage system, the most common type in Australia is primary open angle glaucoma, which is, if you look at this drainage system in profile, where the drainage organ is, basically in most people it should be in like a side view, quite wide open like this, and the drainage happens through the little corner there. So that's open angle glaucoma, and that's because the drainage organ itself fibroses or gets scarred down and is less able to shift fluid in the normal way. And that process is progressive. So it may be a little bit of scarring at the beginning, and then there's more and more, and the capacity to drain outwards reduces. The other type is normal tension glaucoma or normal pressure glaucoma. This is an interesting type of glaucoma because the pressures are technically within the normal range. So usually in the upper limit of normal, somewhere between 15 to 22, but it still causes a glaucoma pattern damage to that patient's eye. And though this condition is a bit mysterious, we know that reducing the pressure still helps. It just means we have to bring the pressure lower for that particular eye. And there are other factors that we think are involved, like oxidative damage. Often it affects the neurons that are more concerned with your central vision because they're more metabolically active, they're doing more work using more energy, and they're more susceptible to damage in that circumstance. So normal tension glaucoma, it's still an open angle, but the eye is just more susceptible to damage, and it's more susceptible to things like low blood pressure, and other problems that can impair the circulation. Like lots of people who have migraine or who have a condition called Raynaud's, where their circulation's not very good and their hands go blue and cold in the winter. All of those things can contribute a little bit. Finally, there's a type of glaucoma called angle closure glaucoma. This is common in certain ethnicities. The vast majority of angle closure glaucoma in the world is in people of Chinese heritage, but also people of Indian subcontinent heritage. And where we talked about the angles nice and wide with the fluid being allowed to get through the drainage system, it's actually really narrow in angle closure like this. So the fluid has a hard time going around the corner and actually getting to that drainage system. Not only that, with the colored part of the eye, the iris, being in such close contact with the drainage system like this, it rubs off a bit of pigment, and that pigment physically impedes or blocks the drainage over time if it's left narrow for long periods of time. So that, in a nutshell, those are the different types, the main ones. There are many other subtypes, like if you've had surgery or inflammation, or there's certain types where the pigment is sprayed in the eye, but those are the main subtypes.
Since glaucoma, as we mentioned before, it does result in irreversible vision loss, and prevention is so important, what are some of the screening methods that you recommend, and how often should people get checked for it?
That's a very good question. So the first two things to realize is that the incidence of glaucoma, or how common it happens, goes up with your age. So even if you don't have it when you're 40, you can get it when you're 50, you can get it when you're 60, you can get it when you're 80. The older you are, the greater risk you are at getting it. And the other really, really important factor is family history. So if there is a family history of glaucoma, you're 10 times more likely to have it than any other person walking on the street. So it's really important to get checked if there's any first degree family member. So that's a mum, a dad, or sibling that has it. But even lots of patients come and tell me, oh yeah, my cousin had it, my maternal aunt had it. So it's not that simple. We know the highest risk is if your first degree family member has it, but any family member can versus risk. Generally, we say that it's wise to get your eyes checked once a year with your optometrist from the age of 40 onwards. If there is a family history of glaucoma, and I usually say first degree or non-first degree, if you know when that person was diagnosed, it needs to be 10 years earlier. So for example, if your brother was diagnosed at 42, you need to get checked from age 32 onwards.
Okay.
The nice thing nowadays as well is once we establish there is a risk, so if you have a family history, we can actually do predictive genetic testing. Super duper easy. You first come for a consultation because genetic testing carries a lot of responsibility and counseling with it. So we do a baseline assessment to see whether you actually have any signs of glaucoma that have declared themselves, or if you're a suspect. And that actually puts the interpretation of the genetic testing in a different. And so then we discuss the test with you. It's a little packet that we give to the patient. The patient swabs the inside of the mouth. It's a bit like a COVID swab, except not the one you jam down your throat. You swab the inside of your cheek. And then you go online, register the kit, send it off. It's all a very secure process. It's protected by Australian privacy laws, and all the data is kept on servers in Australia. So there's sort of, you don't have to disclose it to anyone. There won't be discrimination. This gives us a percentage risk score. So it tests all your genetic material for 7 million variants of genes that can cause glaucoma. And some of them are more benign ones, like I said before, they cause the piddly glaucoma, and some of those genes cause the bad glaucoma. So that gives us information that if you have family history, you don't have any signs yet, but your percentage risk score is low, then we can sort of relax and say, okay, let's screen you every 2 years. Whereas if the percentage risk score is high, then I might say, oh, let's do surveillance every 6 months.
I raised my hand before because I've got a family member who's got glaucoma, so I might have one of the lucky tickets in the glaucoma draw. So I'll have to.
Yes. Well, it's not, like I said, it's not all doom and gloom. Some of the genes are piddly, so that sometimes actually doing the genetic test can relieve a lot of stress and anxiety because when you have information, that's power to intervene and do something about it.
For sure. Well, okay, so there's genetics. Are there any other risk factors that that would lead someone to think they should get tested more frequently? So are things like eye trauma or lifestyle choices? I mean, are there any other risk factors that that you think are worth noting?
Yeah, so anyone who has had a blunt injury to the eye, so like a direct force, even though it may have recovered and nothing has happened, it's a good idea to get screened once a year, because we know people who have had blunt force trauma directly to the eye are at risk of developing glaucoma in their lifetime. And again, that's a slightly different mechanism, but it still holds whether you go and get your pressure checked and get the screening test done, so we can pick it up as soon as it happens. So if the pressure rises, we can treat it before it does any damage to the nerve, and certainly before it does any damage to the visual field. To be honest, the strongest one is family history, but other things that can contribute to it are short-sightedness, diabetes, and we said before with normal tension glaucoma, if you've got things like migraine or sleep apnea or Raynaud's, where your hands go blue in the winter, those are all risk factors as well. If you have a thin cornea at the front of the eye, then your glaucoma may be not detected till earlier on, because the way we check the pressure is to apply an instrument to the front part of the eye, and if this part of the eye is thinner than usual, it's going to give us less resistance. So those are the main ones, really. But the strongest one, like I said, is family history. So, I wouldn't be telling every patient with sleep apnea to go out and get checked, but certainly there is an association.
Right. So you mentioned nearsightedness. So that, I guess,
Yeah.
myopia is a almost epidemic proportions now, and so
100%.
this is like another issue that arises later in life from myopia, doesn't it? Yeah.
Absolutely. So there is a clear association with myopia, and that's twofold. One of them is because myopes in general, not all of them, or short-sighted people, tend to have a thinner front part of the eye. So it might be that when you go to your optometrist and, as the pressure goes up, the pressure may be checked at 19, but because this is really thin, the true pressure in the eye might be 23, which is, a flag raised. So it won't declare itself, or we won't detect it till a bit later on. The other thing is long-sighted eyes short-sighted eyes are longer and is clearer, or the wall of the eye is thinner. And this has biomechanical implications on the nerve. So where the pressure, and this is a very simplified version of it, but where the pressure presses on the nerve like this, if the tissues are more bendy, there is more mechanical damage that participates in damaging the nerve. So that's certainly a way that it can affect it. And the other thing is sometimes people who are short-sighted who have refractive surgery, we know that refractive surgery or laser correction thins the cornea a little bit. So we just have to be a little bit more careful with surveillance. So a little bit more careful. Even if the pressure is borderline 19 or something like that, then we may escalate them for a review with an ophthalmologist. So we need to be more vigilant and not use that 22 as a hard and fast rule. Even if the pressure is like high teens, low 20s, they should probably get checked.
Okay. So thin corneas doesn't necessarily mean that you're more likely to get glaucoma, but it just means that it's more difficult to detect. Is that what you're saying?
100%.
Yeah. Okay.
You got it. Yeah.
And would that also say apply to somebody with keratoconus, because that's another condition that seems to be getting more awareness out there?
Yeah, definitely. So,
Yeah.
actually, I've done a poster at a conference about this before, because there's a particular patient that comes to mind, and the title of the poster was Keratoconus, Inconspicuously Under Pressure. And the reason is, every time this patient came in, the pressure was measured and it was low. And because he was coming in for his keratoconus, this is at the public hospital, and we were only using the eye care, which is the little instrument that just bounces on the front of the eye to check the pressure, which is not as robust, not as accurate, but it's a good screening tool. And when you're looking at patients for other problems other than glaucoma, and so it was kind of missed because his pressure was 16 and 16 and 16 all the time, and then suddenly his vision was worse than we would expect for keratoconus. And we started doing all the glaucoma tests, and we found that actually he has it. And the reason the pressure is so low, in that circumstance, is twofold. One of them is the cornea is thinner, as we've discussed, and the second one is biomechanical factors. So in keratoconus, the cornea is, for want of a better word, more bendy, and so it's easier to depress it and get that pressure reading. And therefore, again, not much resistance is applied, both because of the thickness and the different biomechanical characteristics. And so you end up, it's a double whammy. You end up really under reading the pressure. So patients with keratoconus, we need to be extra vigilant in imaging the nerve, scanning the nerve, and not relying so much on the pressure.
Understood. Okay. Well, if you're watching on YouTube right now and you're getting value from this, and I'm sure you are, can I ask you to please hit the like button, because it helps us out greatly with the YouTube algorithm and improves the odds that other people will get benefit from this also. All right. Well, so glaucoma treatment has advanced a lot in recent years. Could you explain the range of treatment options then, from eye drops to laser, and how minimally invasive glaucoma surgery, or MIGS, fits into the picture?
Yeah, that's a great question, because the exciting thing about glaucoma is we keep learning more and more about treatments that we can employ to buy more time. And why do we want to buy more time? It's because we have an aging population and amazing developments in medicine where people are living longer. So it's important for us to think about that the patient in front of us is going to live for a long time, and we need to keep them seeing for a long time. So every patient that comes to me, I make a plan looking into the future and assume that they're going to live to 100. And here's where all the new science helps us. So the first, I would say, revolutionary idea in glaucoma came in 2019 with the LIGHT trial. The LIGHT trial it studied a treatment we already had and we already used, and we already suspected for many years that it was very, very good as a early treatment, called SLT, or selective laser trabeculoplasty. And what that laser does is, it's a cold laser, so it doesn't actually cause any holes. It just warms up parts of the drainage system. And what we know about it is that we think it changes the collagen or other support tissues to allow more drainage. It's got an 80% success rate when used as a first treatment. And at the 6-year mark, so in 2023, the follow-up study was published that showed at 6 years, if you had laser first versus a drop first, you were half as likely to need surgery for your glaucoma at that time frame. Patients' quality of life scores were better, and they had less visual field progression. So in many ways, the laser can buy us a few years. Now, laser is not a permanent treatment because, as we discussed before, glaucoma is a progressive condition. And actually, going back to your question of what are some of the most biggest misconceptions about glaucoma, one of the misconceptions is that, oh, well, I'm on drops and the pressure's always 15 and that'll be fine, kind of thing. But it's not like that, because it does change over time, and that change might be slow or it might be fast. So depending on how much drainage capacity you have, we may need to escalate therapy. So laser is a good one to buy us a few years off drops. It's a very innocuous treatment, very few side effects, and it can be repeated if it wears off. Next is the advent of preservative-free drops. So in recent years, we've come to come to know scientifically that drops with preservatives in them, and particularly certain types of preservatives, they both affect the ocular surface, reduce the quality of the tear films. Some of them have an effect of actually reducing the amount of tears produced by your eyes. And they sometimes just affect the patient's quality of vision and quality of life, which are things that are previously we weren't so aware of until we started looking at patient-related outcome measures, which is a new thing in the world of science and medical science. And so preservative-free drops are an excellent tool to employ to help patients use their drops and not get red eyes and not get itching and discomfort the whole time. And then, of course, minimally invasive procedures. So there's been an absolute exponential rise in the number of things we can use to help the drainage system, both in the early and moderate phases. So the way I explain it to patients is, depending on how much your trabecular meshwork is draining, we may need to help it a little bit, and we help a little bit with laser, help it a little bit with minimally invasive procedures. And often they come up when we're sort of at the end of the line and the number of drops the patient can tolerate, or we're not getting the pressure lowering that we want, which is called the target pressure. So we set a target pressure for each patient at the outset, and we may need to revise that through their course of glaucoma. Or if they're coming up for cataract surgery. So let's say they have a symptomatic cataract, which is the lens in the eye going milky and affecting the vision. That's an opportunity, because we're already making a microscopic 2mm incision, and we can use that same incision to put in small devices to help the drainage meshwork and reduce the dependence on drops or give us more control. And again, the science behind these devices is many of them work for 5 to even 7 years. Some of them have been around for a long time. Some of them are new, and sort of different types of patients may be more suitable for them. But certainly cataract surgery is an opportunity that should not be missed to enhance the function of the drainage system. The types of things, the types of MIGS or minimally invasive procedures we have, there's the ones with implants left behind, and the ones that where we do something to the drainage system, but there's no implant. So the first one is the implants, and we can put in 3 microscopic stents, and they reduce the pressure by about 1/4 to 1/3 and can last up to 7 years. Or we could put in a little stent called a hydrus, and that basically scaffolds the piping network and has a little snorkel to the front part of the eye, which drains the fluid through. Those are the most common implant ones. More recently, we have something called mini-ject, which is, again, a little stent that diverts the fluid to drain in a different pathway. And then we've got the non-implant MIGS, and the non-implant MIGS are things like injecting some gel into the piping system. So basically there's that little drainage spongy tissue called the trabecular meshwork, and right behind it there's a circular pipe, if you will. So we can inject some gel all the way around to widen it, and that also gives us about 25% reduction in pressure. That's called viscocanelostomy. There's another treatment called a goniotomy, and this means to basically strip off the top of that drainage system that is fibrosed and no longer working, so that the fluid accesses the piping directly. So that's just a very quick rundown of minimally invasive procedures. There's also external lasers that we use on the outside of the eye that have a good pressure lowering effect, and they're quite different from the SLT. They work more on lowering production of fluid rather than enhancing.
So if I'm hearing you correctly, it sounds like if somebody has cataract issues, it may also be a good time to talk with their ophthalmologist about glaucoma treatments and sort of get that done at the same time. Is that right?
I would rephrase that and say it's an unmissable opportunity to get a little bit more juice of glaucoma treatment for you, because we're already there. We're already entering the eye, and anytime we enter the eye, there's risk associated. So it's not like we want to come back and do it later, because that exposes your eye to risk again. And we want to minimize all the risks and maximize what you're getting out of that one trip to theater. So anybody who has glaucoma should strongly consider having a minimally invasive procedure at the time of cataract surgery, but at the same time, while they're aware of how it's going to fit in their glaucoma paradigm. For example, if they're on one drop, having a minimally invasive procedure has a 75% chance of getting off that one drop. If they're on a number of drops, but their pressure is not well controlled, there's a 75% chance of controlling that pressure rather than going on to more serious surgery. And finally, If they can't tolerate a number of drops, but they're taking them anyway because they don't want to go blind, then that's also a possibility that we can reduce the drop burden to sort of just give them better quality of life, better ocular surface, not be bothered by, a speck in the eye all day long type of feeling. So I think I would say it's an unmissable opportunity to discuss it, and what each individual patient expects to get out of it, that's a conversation for them and the ophthalmologist.
Okay, fascinating. All right, well, looking ahead, what promising research or future developments in glaucoma care are you most excited about, and how might they change the way that we treat the disease in the next decade?
Yeah, absolutely. So it's an exciting time to be alive as a glaucoma surgeon.
Wouldn't be dead for quids.
No. And basically one of the most exciting things is actually the future is already here. When I was going through my training, we were always talking about personalized medicine and precision medicine, which really means tailoring treatments and surveillance follow-ups to the individual patient, because we've got all this data about averages and average progression over time, but how does that help us figure out patient with a piddly glaucoma versus the one with a really aggressive type, right? We don't want to over surveil or over treat the one with the mild type, and we don't want to under treat or not review the one with the aggressive type enough. So the most exciting thing is genetic testing, which is developed in Australia. I alluded to it before, and it's available here in Australia. It's so simple, it's non-invasive, it's protected by the law, and it can really, really help the ophthalmologist guide treatment and guide the frequency of surveillance for that patient in front of them, not just based on averages. And I look after one patient who is a colleague of ours, actually, like in the eye health community and the medical community. Genetic testing has helped us make decisions, because it was sort of that time about, should we do surgery? Should we not? Should we wait another 6 months and see what the visual field shows us? And that's how we used to treat people, in a very reactive way. That was probably fair enough, because the treatments that we had and the surgeries that we had and the techniques we were doing those surgeries were perhaps less finessed than they are now. And the risks, we've really managed to get those risks down quite a lot with improved techniques. And so now, using that genetic information, we can proactively treat people and say, look, your pressure is not optimal. We're having damage on the nerve, and it's consistent over 2-3 visits. Why should we wait for the visual field to get worse? We can just take the next step, knowing that you're in the genetically higher risk category. And so this is how it helps us to give the patient information. And, as we all know, information is power to help make decisions. So that's the first exciting thing. Other exciting things, of course, are so looking into the future, the instruments that we have in terms of the scans of the nerve and the visual field testing, I think we're going to basically have a better ability to extract much, much more data out of that and give us more precise data about what is progressing and what is not. And that's certainly in the open angle category. In the angle closure category, what's really exciting is so many people have narrow angles, like we discussed, the ones that look like this, but we don't know which ones are going to go into closure or develop pressure problems. And there are new studies looking into what we call anterior segment OCT, which is imaging, having really good cross-sectional pictures of the corner, 360 degrees of the eye, the size of the angle, the shape of it, 500 microns from the corner, how wide is it, etc. And those can all help us identify which patients are actually going to get the angle closure glaucoma, or are actually at risk and need expedited treatment. And other things, of course, it's going to help us assess how good our surgeries are. So with advanced imaging and AI to look at those images and extract all this data from it, it's going to enable us to know a little bit more about the success of surgery and who's more suitable for which type of surgery.
So, of course, AI is revolutionizing so many things at the moment, but it sounds like it's also playing a big part in driving innovation in your world as well.
Absolutely. So it's going to be a good decision support tool. And I use that word carefully, because AI can only identify links. It cannot identify causation. And some things that are linked may not necessarily be causal. So one may not lead to the other, but they just appear together more frequently for other reasons. And hence why you still need the human to do the higher processing of all that. Right. And you still need the human to talk to the patient and help them decide this sort of the science sort of things. But then there's the patient and their lifestyle and their responsibilities more often than not that drive the decision making. So even though the science can tell us A, B, C, and this is better, we speak to the patient about it, but actually the patient says, actually, I can't, comply with this post-operative regimen. So we need to do something else in the meantime that's perhaps less favorable scientifically. So not as the science doesn't show that it's as robust, but it's going to buy us a little bit of time until their situation improves and we can do something else.
All right. Well, we might wrap up soon. I think I've got to say, Dr. Ali, I think you've given one of the best explanations about glaucoma that I've ever listened to. I really learned a lot from you today.
I'm glad to hear it. So I hope it's helpful for your viewers as well.
Indeed. So, do you have any last words of advice for people who feel they need professional help with glaucoma treatment?
Yeah, I think don't be anxious and don't be afraid. It's and sometimes we react in ways where kind of not thinking about it helps us cope with it. But I think nowadays, knowing that there's a low risk of going blind with good risk assessment and intervention, it's just better to get checked. So just get checked with your local optometrist. It's as easy as going in on your Saturday after you've done your grocery shopping and with an appointment, of course. And get your pressure checked, get your nerve looked at. If you've got a family history, please let the optometrist know. Don't leave them in the dark, because that'll trigger them to do a number of other things to look after you. And if you're really, really worried and you've got that family history, you can come straight to the ophthalmologist and we do a risk assessment and combine that with the genetic testing to give more precise answers. But it's definitely not something to be afraid of. It's something to be proactive about. And, for most people, it's like a get checked, get reassured, and, revise every 1 to 2 years without any problems.
Excellent. All right. Well, so for people who want to reach you, if they're curious about having a consultation, how should they go about that?
Yep. So basically, they can reach us at www.eagleeyesurgeons.com.au, and our email is admin@eagleeyesurgeons.com.au, or they can just give us a call on 027228 3900. We do need a referral from either your GP or your optometrist, and that's just for you to get your Medicare rebate. But by all means, people are welcome to come and see us for an assessment, but we want to obviously be able to give you that Medicare rebate, so you've got to have the referral with you.
Of course. All right. Well, once again, for anyone watching, if you've found this helpful, we'd love you to hit the like button, so that helps others to find it too. And of course, subscribe to the Eagle Eye Surgeons YouTube channel for more useful content like this. And also follow the Facebook page and Instagram account for updates on the latest treatments, promotions, and events. So thank you so much, Noor, and thanks everyone for watching.
Thank you, Paul, for helping shed light on this important condition.
Thank you. All right. Bye for now. Bye-bye.